This is an ABC podcast.
Hello and welcome to the Health Report with me, Norman Swan. Today, where 3 into 1 does go, at least when it comes to treating high blood pressure more effectively. If you can Google in an emergency, is it an emergency? And how to make our hospitals safer. The Grattan Institute today claimed in a report that if all hospitals were as safe as the top 10%, then $1.5 billion and 250,000 complications would be saved and 300,000 more patients cared for. But argued the way we monitor safety at the moment is inefficient and not working. They're talking about the set of national standards laid down by the Australian Commission on Safety and Quality in Healthcare, which are assessed by independent assessors to allow the hospital to be accredited. That's the nice sign that's usually on the doorway when you walk into the foyer. The implication is that the standards and accreditation scheme should be junked. Interestingly, at the same time, the Commission has released its own review of the accreditation scheme, announcing 6 strategies to improve it. This might sound esoteric, but it's actually all about the safety of the care that you get when you enter our hospital system. In our Melbourne studio is Professor Stephen Duckett, who heads the Grattan's Health Programme, and in our Sydney studio, Professor Anne Duggan, who's the Acting Chief Medical Officer of the Australian Commission on Safety and Quality in Healthcare. Welcome to you both.
Thank you.
Thanks, Norman.
So, Stephen, why are you so down on the accreditation scheme as it exists?
Well, I think it's done it does a fair amount. It provides these surveyors and so on. But what we see is that the rates of complications are still pretty high. About 1 in every 4 people who go into hospital for an overnight stay have some sort of complication. About 1 in 9 or so for people who are in any admission. And many of the hospitals that have had serious complication scandals have been accredited for the years previous. And so this causes one to stand back and say, well, can we do better? And the Commission is trying to do better, but we're saying we need to go even further than that. So, and do you dispute any of that? I mean, you've come out with a review. Obviously, you think there's something wrong with the accreditation system to have come up with 6 strategies to improve it.
Norman, as you know, I'm a clinician and I've been a clinician for over 20 years. I won't tell your listeners just how long I've been a clinician. And I think I've seen the change because I've seen the national standards, which became mandatory in 2011, come in. And to explain to the listener who hasn't got a clue what we're talking about here, the national standards are things that hospitals have got to meet, like wound infection, like not allowing elderly patients to go into delirium and things like that. That's right. So they've been focused on as you know, in medicine we say common things happen commonly. And the common areas of complications are infection, falls, pressure injuries, failure to recognise deterioration early, medication areas. The standards are focused around those key areas. And what we've seen since the states and territories and the Commonwealth and Commission put them in place, we've seen a marked improvement. So
not in all of them.
No, you've got to start somewhere.
You're a bit better in antibiotic prescribing, a bit better in wound infection.
Absolutely. But if you take...
But the list runs out, doesn't it?
No, if you take New South Wales, for example, where we had the Between the Flags program, which is a trigger system for recognising patients who deteriorate, their review showed a 50% decline in in-hospital cardiac arrest. That's a huge personal impact. That's major. If you look at infections, for example, and you look at bloodstream infections, and that's done per 10,000 patient days, we've seen over a 5-year period a drop from 1.1 to 8.7. We've seen hospitals having to putting in place antimicrobial stewardship programs over a 5-year period, going from a third to 98%. So that's led to reduced inappropriate antibiotics prescribing.
But you argue, Stephen, that high-performing hospitals are not ones that necessarily conform to the 20 or 30 standards that might be in the Commission's list.
I think there are a couple of points here. There's improvements happening everywhere, and we know that, and that's really good. There's improvements happening in the United States, in England, and so on. If you take the central line-associated bloodstream infections, that's coming down all over the world because we've said this is no longer something that just happens. It can be preventable and it should be zero.
So a central line being a line that goes into your heart for chemotherapy and things like that.
Yeah, and so the rate should be zero. It's not zero, unfortunately, in Australia. There are many hospitals where it isn't.
So what are the features of a high-performing hospital? Because you're arguing that if you just aspire to everybody achieving the high 10%.
Yeah, well, so what we're saying is the problems in any hospital is not going to be the same as in every other hospital. And we're saying that a one-size-fits-all, a set of standards that have been developed nationally are important, but really we've got to get each hospital to focus on what the problems are in that hospital and focus on any complication that occurs, not necessarily a complication which is on this standard list or whatever, and they should be striving to improve themselves. They need data to be able to do this, and the best hospitals are those hospitals which have got a quest and a zeal for improvement and are getting their rates down right across the board.
I mean, how do you respond to that? And because there's cynicism at hospital level. The hospital knows that there's an accreditation coming. They dress it up. They game it. Everything's polished and looking very shiny for the surveyors arriving. And as Stephen alluded, some hospitals pass accreditation with flying colours and then turn out to be disasters.
I think the first thing, Norman, is that the workforce are committed to patient safety. So there's a whole lot of workforce there. You can't for a moment suggest that if you have in place a deteriorating patient program or an antimicrobial steward patient program, that the day after the surveyors come, that we just pack up and go back to bad practice. I mean, that's just not fair on clinicians.
But I think Stephen's point, or Stephen can make his own points for himself, but I mean, Stephen's point is that you focus on these standards and you kind of miss the real picture, where you might have a problem in your urology department or in your neurology department, and that doesn't conform to standards, and you end up with a low-quality hospital, but it looks high quality because you're conforming to the Commission standards.
Remember Willie Sutton, the bank robber, and when the judge said, why do you rob banks? And he said, well, that's where the money is. Well, if you look at the standards, they're focusing on the key areas where patients are most vulnerable. Now, yes, there are other issues where we should be doing work on that are specific to different specialties. That doesn't say, as a gastroenterologist, I'm not looking at those special areas. But every patient who comes into hospital is at risk of infection, medication.
But how do you incentivise, Stephen, the hospitals to look across the board rather than, or in addition to, the standards set by the Commission? I mean, for example, we pay hospitals for complications. Presumably they can make a bit of money out of poor quality care.
Absolutely. Because of the way activity-based funding works, for public hospitals at least, they get rewarded for having a complication. But we looked at the 20 biggest public hospitals in the country, and we showed that in every case, they lost more money, that is, complications cost more than the revenue they gained. Not only that, was more than twice as much. The costs were more than twice as much as the revenue. So they've already got a sort of their own internal incentive. Of course, as Anne points out, every clinician wants to do the best as well. But what we also found, that in a given hospital, a high-performing orthopaedic surgery department might exist alongside a low-performing cardiology department. That is, there's no correlation between the complication rates in the same hospital. And so this means that hospital-wide strategies are probably not where you want to be putting all your energy. You want to be actually focusing on the medical tribe, saying to the orthopaedic surgeons, you've got to be as good as that orthopaedic surgery department down the street, because they're doing so much better than you. And so what are your problems? It might be have nothing to do with infection rates. It might be they're having problems in theatre and they're getting more procedural problems, procedural complications, returns to theatre, and so on. So the problems differ across different hospitals.
So, Anne, which of your strategies do you think address some of Stephen's concerns? Because, I mean, it's kind of as if you're both right.
Well, yes, and I think the thing is you've got to work out where you start off, and I don't think...
But you've been doing this for a while. They're already on the road.
Yeah. So, but I think the other thing is that it's not as though hospitals aren't doing things above and beyond. Now, as Stephen points out, you might have variation in your orthopaedic department or something. Now, the next set of standards, which come out in beginning of next year, have a specific standard, 1.28, on variation. So it's expecting clinicians to look at why do we differ. The other thing about the accreditation system is that next year we're having hospital reports will be published. that gives the level of detail that
With
gives
the names
hospitals.
of surveyors on it?
I don't know the details of that, but there's certainly work to make sure that there is better training for surveyors, to have more consistency in rigour, so that
So, Stephen, how would your accreditation system work if you said, well, we're going to go much broader than the standards and look at a granular level at all hospital complications? How would you accredit a hospital who's doing that and not to a specific set of standards? Isn't that going to be anarchy?
No, I think what we've got to do is get away from the finger-wagging sort of accreditation certificate on the wall and saying, look, we passed on the 20th of August, so it must be good forever. What we want to do is say to the hospitals, here's your data. Have you analysed it? Have you got a program that actually leads to improvement, that is all about how you compare with the best in Australia? And then you have the surveyors come in and they look at that data and they say, what are you doing? And provide feedback and help the hospitals improve themselves. You've got to actually empower the clinicians, empower the hospitals. You've got to actually be using the data, the real experience of that hospital, how it's going, not whether it's actually got a document or a plan or a strategy about infection control, but what are the infection rates like in that hospital?
So your strategy number one is to improve the, I quote, veracity of health service organisation assessments. Does that mean you suspect they're not true?
I think in the past there have been some criticisms of the surveying process. And remember, there's a difference between the singer and the song, and you're trying to improve the singing. I think, getting back to Stephen's point though, I think he's talking about things that are actually part of the accreditation process going forward. If you have no notice assessments, you know what's going on every day of the week. If you publish reports...
So you're going to have... Your proposal is like Stephen's, somebody will just arrive on a Wednesday unannounced.
This is out and published as to what the surveying process will look like in the future, as in coming next year. Publications of reports so that you can, as a hospital, look at a peer group and see how you're travelling. And you can go to the top 10 in your area and ask them how do they do it. There will be support for hospitals that do need assistance to get to the top 10.
Okay.
And I could go on.
So, Stephen, what you talk about financial incentives here. I mean, there's obviously a disincentive for poor quality care, but what incentives are you proposing?
Well, as I said, what we want, there are already hospitals have their incentives because complications cost more than they gain in revenue, but there's probably not a hospital in the country that knows that. What we're saying is hospitals need to know. They need to have much more information. It's all very well to have, for us to be at Grattan Institute to be able to calculate that, but, if a clinician comes along to a manager and says, look, we've got this issue and so on, the manager needs to say, look, these sorts of complications cost this hospital this amount of money. We want to help you, and there's a business case here to improve quality so it actually benefits the patient and the hospital's bottom line at the same time.
Which is one of your strategies, isn't it?
Yes,
kind of. Anne?
But I'd also say that I don't think clinicians actually respond to data on the basis of how much money it saves. I think they respond to, this is a complication, we want to do the best thing by the patient. And I think that knowing how you're travelling, like knowing, for example, as I talked about between the flags, what's happening in terms of cardiac arrest, they respond to that sort of data, which, remember, hospitals have been reporting sentinel events and adverse events for over a decade now. So we do know a lot about how we're travelling, and clinicians do respond to that.
And what about
we can always get more data, absolutely.
And what about disincentives? So, for example, Stephen talks about the granularity that you might have a good orthopaedic department and a poor performing cardiology department. He's suggesting in his report that medical colleges should not send specialist trainees to hospitals where if you're a cardiology trainee, you can't go to hospital X because they're not up to scratch.
Having sat on the training program for my specialty, I think it's a very complex idea to try and work out the realities of that.
The data would be pretty hard, wouldn't it?
Oh, but in terms of how the colleges would respond, what they would do, I think it'd be very interesting to go down that path.
the college is always more interested in their own life than their patient safety. Is that what we're saying?
No, I'm not, not saying that at all, Norman. I'd have to think that one through and they would have to respond to that. It's an interesting idea.
Thank you very much to you both. I hope you as an audience followed all that, but it's really actually important stuff. Professor Stephen Duckett heads the Granton's Health Programme, and Professor Anne Duggan is the Acting Chief Medical Officer of the Australian Commission on Safety and Quality in Healthcare. We'll try and have some links on our website to those reports. You're listening to The Health Report here on RN, ABC News and CBC Radio across Canada. I'm Norman Swan. Next to smoking, high blood pressure is probably the most toxic risk factor for early death and disability from heart attacks, stroke, probably dementia as well. Recently, the United States lowered the level at which high blood pressure is defined, but even at the old levels, many people are poorly treated with blood pressures which are too high, even on medication. Now, a trial run by the George Institute at the University of New South Wales suggests that instead of using one medication at a time, using 3 at once in low doses might be more effective and cheaper. Ruth Webster was the lead author and is with us now. Welcome to the Health Report, Ruth.
It's a pleasure to be here.
Why did you think of this 3-drug option?
There's a lot of research that has shown that, for example, patients with high blood pressure, the majority will need at least 2 blood pressure drugs to control their blood pressure. We also know from previous research that about 80% of the efficacy of any blood pressure lowering drug happens in the first half of that dose, whereas most of the side effects happen in the second half or higher doses. And
so in other words, you once you're increasing the dose to try and get better pressure, you're increasing the risk of
side effects.
Side effects.
Correct, exactly. And so what we tried to do is join some of the dots in the established research and show that if you went straight for multiple drugs at lower doses, you could get better, faster blood pressure control, less doctor visits, less side effects, and by combining them into one pill, you can make it much more convenient for patients to take.
So you did this in Sri Lanka?
We did, yes. It's a lovely country.
I'm sure it's
Beautiful
a lovely country, but are results in Sri Lanka applicable to Australia?
Yep, that's a good question. We did it in Sri Lanka. We had very good collaborators there, and it's a country that has about a 25% rate of high blood pressure, so is a good country to do a blood pressure trial.
Which is similar to us.
Which is very similar to us. And so, yes, we would say it's obviously needs to be replicated in more settings, but the control rates that we got in our usual care arm in Sri Lanka are about equivalent to Australia, the US, the UK, any of the high-income countries across, pretty lousy. Equivalent to high-income countries across the world.
What proportion of people have their blood pressure controlled? When I was a medical student, we were talking about the rule of halves. Half of people don't have blood pressure recognised, only half are properly treated, and then half of those don't have their blood pressure controlled. Is that still true?
It's probably even worse now. The figures currently quoted about a third of people globally with high blood pressure have their blood pressure controlled. So it's not a lot, and there's a lot of room for improvement.
Okay, so what were the 3 drugs that you used?
So we used drugs called telmisartan, amlodipine and chlorthalidone. The actual drugs themselves are probably not as important as the concept of 3 at half dose. We just chose sensible drugs that with long half-lives so that you could take them once a day to, again, a convenience factor, and then they had no contraindications to be taken together.
What did you find?
We found in our usual care arm, as I mentioned, we had about half of the people who were controlled by the end of the study. In our active arm, we had 70% control. And although we measured that at 6 months, we actually found that the result was clear by 6 weeks. So it was very fast control of blood pressure and a very demonstrable improvement in the number of patients controlled. So
controlling blood pressure that fast, does that give you side effects like standing up and fainting and stuff like that?
Sure. Taking blood pressure lowering medications, there's always a risk of side effects. Any medication has a risk, but we didn't show any difference in side effects between the 2 arms of the trial. And that's probably quite important because...
I thought you were expecting fewer side effects.
Well, yes, exactly. However, what we were doing in the trial was putting patients onto 3 drugs straight away. And most of the people in the usual care arm were still on 1 drug, but at higher doses. So even though we were increasing the number of drugs they were taking, there was no increase in side effects. So for me, that showed that, there was an overall net benefit in side effects, even though the actual amounts were equivalent in both arms.
How bad was their blood pressure?
They started off at about 155 of the upper measurement of blood pressure, which is... It's probably classified mild to moderate blood pressure. This is not severe blood pressure. So what we were...
Depends whether you're American or not.
Well,
Americans would think you're blowing your head off at
well, exactly. They have lowered their targets now. So we were particularly looking at patients with, I guess, in an area where you traditionally start with 1 drug, titrate up, start a second, titrate up. And so we were deliberately going for that mild to moderate and initial therapy, so early in that treatment process.
So if you're listening to this, and a lot of people listening to this will have high blood pressure, either they'll know it or they won't know it, but if they do know it, obviously there's lifestyle things like taking moderate exercise will lower your blood pressure similar to a blood pressure tablet, lowering your salt intake and lowering your alcohol intake. So those are the things that we know our lifestyle will make a difference. But you're on medication. I mean, can you go to your GP and play around with a low-dose regime, even though that you can't get it in one tablet in Australia yet? Absolutely.
It obviously depends on your GP, but certainly go and talk to them about it. All of these, there's multiple blood pressure lowering medications available in Australia. You can take them at low doses. There's not one low-dose combination therapy available on the market yet in Australia, and that's something that the George Institute is trying to advocate for.
Now, we've had the George Institute on before talking about the polypill.
Yes.
So the polypill is not just 2 or 3 low-dose blood pressure medications, it's low-dose, so it's aspirin, I think is in there.
Aspirin and cholesterol-lowering medication.
Correct. What's the latest on the polypill? And the idea here is that you put this in the tap water. I mean, basically anybody over 50 would have a polypill, particularly if they're at high risk.
That was the original premise back in 2003, and we don't all necessarily agree with that approach. So yes, the latest is that there is a polypill available on the market in about 37 countries now. Australia is not one of them, but New Zealand has received marketing approval for one, so it's getting closer.
Right. It's across the Dutch.
It is, that's right. It's not that far away. You could probably swim. And what we're now moving towards is looking at generating the evidence of how to include that in our current clinical practice. So it's coming. Snails probably move faster, but we're getting there.
Watch this space.
That's right.
Because you'll hear it first on the Health Report.
That's right.
Ruth, thank you very much for joining us.
Absolute pleasure.
Ruth Webster heads research programs at the George Institute in Sydney. Searching for health information is one of the commonest reasons for using the internet. Some doctors complain about patients who arrive with reams of internet printouts. But it's an open question whether consumer health searches improve or detract from their medical care. For example, does it make them doubt the doctor's diagnosis and less likely to conform to advice? Does it terrify them? Well, one of the first ever studies of the effects of health searches on patients arriving at emergency departments has been published this morning. Maybe this will be a new standard for the Safety Commission. And the news seems to be good. Jenny Hutton is an emergency physician at St Vincent's Hospital in Melbourne and was one of the researchers. Welcome to the Health Report, Jenny.
Hi, Norman.
So what did we know about internet searches in health and its impact on healthcare before you did your study?
Not much. There's, as you probably know, there's a bit in GP setting and there's a bit in paediatric emergency setting, but there's not a lot in the emergency setting and there's none in Australia.
What did we know from the GP setting?
Well, a lot of people do it and there's a mixed response to GPs, and on the whole the patients previously thought it was quite a positive thing, and the majority of GPs thought it was a positive thing as well.
So tell us what you did in your survey.
We got 400 patients that presented to 2 hospitals, either the Austin north of Melbourne and St Vincent's in Melbourne, and we asked them a 51-question survey about their internet use.
And?
Well, we found that
before you go on, 51 questions?
Yeah, well, we included 2 indices.
So they weren't dying. I mean, they weren't sort of like on a major resus with a tube down their throat or a major car crash.
Well, exactly.
So
we had to
exclude.
we had to exclude that sort of group of people, obviously.
Yeah.
And we just asked the rest that we could consent to do the survey, what they Googled and how they Googled and when they Googled. And we found that a third of patients presenting to ED searched the internet about the problem prior to presenting, and that frequency increases to 60% in the 18 to 29-year-olds.
You also assessed something called e-health literacy. Tell us about that.
Well, that's a validated index from America that's been used on a number of studies, looking at basically how comfortable people are negotiating the internet to look for reliable sources and understanding that. And it's a 9-question index looking at those factors about searching.
So when you say it's validated, because one of the issues is that, if you search on immunisation, really dubious websites come up that are anti-immunisation. And if you're not aware of that, you could be deluded. Anorexia nervosa is another classic one. If you search on anorexia nervosa, you'll find sites that actually encourage eating disorders amongst young women in particular. So if somebody thinks that they know how to assess a website, How actually true is that?
Well, that's a good question. It does look at the confidence they feel in doing that. It's self-report, as you say. So, but if they're confident in doing that, you're hoping that they're able to do it.
So what did you find what was the correlation? What were you looking for in terms of a correlation between their internet use and their outcome in terms of the emergency department consultation?
So we looked at the doctor-patient relationship, and most people, 77%, said they had a positive experience from doing the search.
And that was greater than the group that didn't? They got more out of it than others?
Yes, exactly. The majority of people said it was a positive experience. And in particular, they said it helped them answer better questions from the doctor.
Did it actually make them, one of the questions from previous research is that it can make you anxious because you think you have cancer when you might not have, and or it makes you question the doctor's diagnosis and less likely to accept the therapy.
Yeah, we did ask those questions, and we did find that there was a downside, and that 40% of our people we surveyed did say that doing the internet search had made them more anxious. In regards to diagnosis and treatment, we found that 90% never changed their treatment if they found conflicting opinion on the internet as opposed to their doctor.
What do the doctors think?
We didn't do that study, I'm afraid.
It doesn't matter, these doctors. What does it matter that they think? So here you have a group, 25 to 30. Now, there were the walking wounded. I mean, how applicable is this to general practice and emergency? So in an emergency department, they're going to see a younger doctor. They're going to see a year 2 or 3 doctor in the emergency department, not a GP. And with all due respect to GPs, they are an older cohort and less savvy. So they might be seeing their peer group when they go in. It's a very different doctor's consultation from elsewhere. And, if they're well enough to do a search before they come to an emergency department, is it an emergency?
Well, we see a lot of things that aren't emergencies, I suppose, is the general perception of it. There's things that are urgent, and then there's things that are important, and some things that are both urgent and important, such as an anaphylactic reaction. But if you had abdo pain and you thought it might be appendicitis, you're probably better off going to an emergency department than you are to a general practitioner.
But I suppose my question is how applicable it is. I mean, this is a group of people who use their emergency department as their general practice rather than going to general practitioners, isn't it? I mean, I'm changing the subject slightly.
No, not necessarily.
Oh, that's a typical ED physician's view, justifying all the people that come in your door, isn't it?
No, not necessarily. There's evidence that a lot of people that come to emergency actually need to be there.
Look, Jenny, great. We'll look forward to talking to you when you've actually spoken to the doctors. Love to know what they think.
Great. Thanks, Norman.
Thanks very much, Jenny. Jenny Hutton, who is an emergency physician at St Vincent's in Melbourne. Now, a correction on one of the stories we ran last week in our segment on glyphosate and Roundup and the risks thereof. Professor Lynn Ritchie said that in Australia, pesticides don't have instructions on how to use them on the bottle. She said instead you have to go and look for the safety data sheet. The Australian Pesticides and Veterinary Medicines Authority, the APVMA, got in touch and said that's not true. Australian law requires appropriate warnings on product labels, including personal protective equipment when using products containing glyphosate. And the AVPMA statement is on our website. And also good news, Dr. Hadiza Bawa-Garba, you might remember that story from a few months ago, the doctor in Britain who was struck off because of an unfortunate, in fact tragic case in Leicester. She won her appeal against being struck off. And if you're in Melbourne, a heads up about 4 ABC events on science in society we'd love you to be part of. Join RN's Natasha Mitchell for Science Friction Live at the Melbourne Museum. Kicking off on September 6th, there'll be lively, robust discussions from the Me Too movement in science to the future of sex, the failure of science in schools and more. They're free, but you do need to book. Head to events on the RN homepage for more information. abc.net.au/RN. This has been The Health Report. I'm Norman Swan. See you next week.